live.
Yeah, thank you. Thank you, Exicon. Good evening and welcome you all for this evening, the Tamil Nadu API-ICP Postgraduate Virtual Training Program. The last week of the presentation by the Madurai Medical College, Department of Medicine, we have with us Dr. Natarajan sir, Professor and Head of the Department, being the faculty for this evening. Really thank you, sir, for being the faculty for this evening and for completely accepting our invitation and allowing your faculties to be part of this program for the past 16 weeks and encouraging our postgraduates to participate in this presentations program also. Really thank you, sir, for being this evening. And we have with us the coordinator for this program, Dr. Fayez. Really thank you, Dr. Fayez, and being the coordinator. And today I'm expecting you to be one of the faculty also this evening. And we have with us two postgraduates from the Department of Medicine, Madurai Medical College. We have with us Dr. Divya and Sharada, going to present two important the hematological problem which we face in a daily practice. One is on the platelets, other one is on, I would say that case could be discussed as a new onset of bleeding disorder. And over to the presenters and the faculties, Dr. Natarajan sir and the Fayez to take over the further proceedings of this session. Thank you.
Sarada, you can start your presentation.
Good evening, sir. Today I'm going to present a case of immune thrombocytopenic purpura. Chief complaints: a 53-year-old female, agriculture by occupation, hailing from Tirumangalam.
So you are not changing your slide. Only the topic is there. You are not sharing your slide. It has got stuck up with the immune thrombocytopenic purpura. You want the next slide? Yes, and again, yes, now it's correct. You go slowly, and but this is going to be a very common topic. So we'll discuss in detail about this. And if time permits, we'll go for the second case also.
Okay.
Go to the, good.
A 53-year-old female, agriculture by occupation, hailing from Tirumangalam, who was a known case of ITP and post-nectomy done 3 months back, came with chief complaints of bleeding from surgical site for past 2 days.
Okay.
History of presenting illness. Patient was a known case of ITP, was apparently normal 3 months back. Then she developed oozing from surgical site, serosanguinous discharge and not associated with pain or fever. And then for past 2 days, bloody discharge from the surgical site. History of easy fatigability is present. No history of fever, no history of abdominal pain or swelling, no history of bleeding gums or epistaxis, no history of headache or vomiting.
Okay, now she will. When she has undergone the splenectomy, any idea?
3 months back, sir.
Okay, now for 3 months she was perfectly normal.
Yes, sir.
For these 3 months, was she on any drugs or she was off the drugs?
Off the drugs, sir.
So she probably it has gone for remission. She was perfectly normal. Now she has again developed bleeding tendencies. Okay.
Yes, sir.
Okay. Now she has developed bleeding only from the surgical site.
Yes, sir.
No other bleeding tendency anywhere in the body.
No, sir.
So we'll start with that. So which are the sites of bleeding which will give importance? So probably this is a herald for severe bleed.
Okay. Yeah, intracranial bleed.
Okay, that's intracranial bleed is a severe bleed. So what are the herald? What are the markers for such a massive bleed?
Wet purpura.
Wet purpura, good, very good, very good.
Retinal bleed on fundus examination.
Wet purpura. So what do you mean by this word wet purpura? So any purpura or any bleeding tendency in the mucosal membrane area. So that's wet purpura. And if it is in the skin, it is dry purpura. So wet purpura is a marker for a future or immediate heralding severe bleed such as
bleed.
Okay. Any other site which will be a marker for forecasting a severe bleed?
Intraocular
Hematuria.
massive hematuria.
Hematuria itself, even mild or so, wet purpura and hematuria. These two, they are the harbinger for a severe bleed. So you should, so that means it's an indication for immediate transfusion, immediate platelet transfusion. So now this patient has got no wet purpura, no hematuria, only bleeding from the surgical site, that is from the drainage tube site, DT site, only she has got a bleeding there. And you are sure she was not on any drugs for the past 3 months.
Yes, sir.
But she is a known case of ITP.
Yes, sir. Known case of ITP for 10 years, sir.
Okay, we will go to the next slide. Okay.
No history of melena or hematemesis. No history of decreased urine output. No history of bone pain. No history of hematuria. No history of breathlessness. No history of altered sensorium. No history of seizure.
Okay, fine.
Coming to past history, a known case of hypothyroidism since 12 years of age on thyroxine supplements, and known case of
what is the hematology of hypothyroid? Does it interfere with the hematology?
macrocytic anemia.
Okay, so the commonest is it is produces a macrocytic non-megaloblastic anemia. Then it can produce menorrhagia and iron deficiency anemia.
Thrombocytopenia.
So this person who has already got thrombocytopenia, if the hypothyroidism is uncontrolled, the menorrhagia will be profuse.
Yes, sir.
Okay. And the link between hyperthyroidism and your case?
Hypothyroidism.
Hyperthyroidism can be produced autoimmune.
Okay, so there is a close association between, so all hyperthyroid patients should be followed up for ITP, and for all ITP patients should be screened for hyperthyroidism. So they are linked. The association is well known. So this person should be followed up for that also. Okay, and any drug related to thyroid can produce thrombocytopenia?
Carbimazole.
Yeah, antithyroid, particularly imidazole, that is carbimazole, methimazole, they can produce bone marrow suppression and can produce thrombocytopenia. So they are the connection. These are the connection between thyroid disorder and platelet. Okay, proceed.
Known case of chronic ATP for 10 years, refractory to medical therapy.
When do you call chronic ATP? What is the duration?
More than 12 months, sir.
12 months, good. So, and new onset is?
Within 3 months.
3 months. New onset is less than 3 months, and 3 to 12 months will be?
Persistent ITP.
Persistent ITP, and more than 12 months will be chronic ITP. So, since she has crossed that chronic ITP, so why do you want to classify like this? So once they enter into the chronic ITP stage, they never go for remission. So new onset or persistent, there's a chance for remission, spontaneous remission or your drug-induced remission. But chronic ITP, once they enter into that stage, the chances of remission is very less. So they have to be on long term, and they can even become refractory. So most of the refractory ITPs are chronic ITPs, or they may require lifelong drugs, at least about twice a day, twice a week, steroid, something like that, to achieve remission. So that's the purpose of classifying into this chronic ATP patient. Means you have to be very careful, and they are also prone for severe bleeding complications also. So intracranial bleed is more common with chronic ATP rather than persistent ATP and new onset ATP. So you watch for complications, and the chance of remission is less in chronic ATP, and they should be on long-term drugs. So, okay, fine.
Known case of type 2 diabetes mellitus for 2 years on oral anti-diabetic drugs, and history of subarachnoid hemorrhage with SDH 3 years back, and not a known case of systemic hypertension, CAD, and CKD.
Okay, and so if she develops a CAD and all, it is very difficult to manage because we have to give them antiplatelets.
Antiplatelets.
Are these people, ITP people, prone for thrombosis?
Yes, sir. Because the patient had undergone splenectomy, she is more prone for thrombosis. Sir.
Okay. Then what are other causes for thrombosis in ITP individual?
Secondary to APLA, sir.
Okay, if I'm asking simple primary ATP, are they prone for thrombosis? One is you have told a very valid point. After splenectomy, they'll have there's a more chance because of thrombocytosis, leukocytosis, and they are more prone for
Glucocorticoids also can cause.
good glucocorticoid therapy. It can trigger
IVIG treatment.
IVIG. We have presented already one case of thrombosis due to IVIG. IVIG itself and all your thrombopoietin receptor TPOA. So they'll have rebound thrombocytosis. So when any ITP patient, primary, I'm talking primary ITP, they are still prone for thrombosis, not per se because of the disease, but most of the time because of the treatment. Splenectomy, IVIG, glucocorticoids. So they are equally prone, not only venous thrombosis, arterial thrombosis also. So it's still, and if there's a CAD, the problem is multifold. Okay, proceed.
Coming to personal history, mixed diet, appetite normal, normal bowel and bladder habits, no known food or medication allergy, and no adverse social habits.
Fine.
Coming to the menstrual history, para 3, live 3, and no bad obstetric history, attained menopause at 48 years of age.
Okay, that's fine. That is blessing in disguise because it's very difficult to manage. Okay, she didn't have ITP during pregnancy.
No, sir.
So that is also probably a plus point for her. And because what are the causes for thrombocytopenia in pregnancy?
Gestational thrombocytopenia.
Okay. Can you tell me 1 or 2 points on gestational thrombocytopenia?
Gestational thrombocytopenia, it will be mild, sir, and it will be more than 70,000. Platelet count will be more. It never go less than 20,000, and bleeding manifestations
usually doesn't go less than 1 lakh. There's a usual cutoff. Very rarely it goes below 1 lakh. Okay, then?
And no bleeding manifestations are very less, sir.
So it is asymptomatic. Gestational thrombocytopenia is an incidental hematological finding. It never bleeds. So it doesn't.
It resolves after the pregnancy.
Pardon?
It resolves after delivery.
Delivery, good.
Thrombocytopenia becomes normal.
So it can recur in the subsequent pregnancy also. It is more common with the twin pregnancies.
Yes, mid to second trimester.
Okay, so it's the second trimester more common in the twin pregnancies. And what are the mechanism for gestational thrombocytopenia? Proposed mechanism?
One is hemodilution, sir.
Okay.
Other one is
subclinical
coagulopathy and endothelial cell injury and immune destruction.
They are all, because then they are all pathological. So the clue is twin pregnancy. That means they are sequestrated in the placenta. So twin pregnancy, they will have 2 placenta. So the main mechanism is sequestration of platelets in the placenta, in the spleen. That's the main mechanism. And it is usually doesn't fall below 1 lakh, rarely around 50,000, always asymptomatic, and it tends to recur in the subsequent pregnancies also, doesn't warrant any therapy. Okay. Other causes for thrombocytopenia in pregnancy?
Acute fatty liver of pregnancy.
Good.
APLA. DIC can occur. Pre-eclampsia, and HELP syndrome.
HELP, that is very, very common. So HELP, you'll have low platelets. Okay.
And the fatty liver can occur in third trimester of pregnancy, sir.
Is the increased incidence of ITP in pregnancy?
Yes, sir. Okay. Pregnancy itself can induce ITP.
So it is called immune dysregulation state. Pregnancy is called immune dysregulation state. So either thing can happen. All the immune mediated disorders can go remission, persist, or new immune disorders can appear. So immune dysregulation state. So ITP, new onset ITP is quite common in pregnancy also. So we have to find out whether it is new onset ITP or other gestational thrombocytopenia, HELLP syndrome, preeclampsia. All these things we have to find out. Okay, now coming back to the history, she is a known case of chronic ITP. And what was the previous treatment she was getting? Treatment is you have not touched upon. Only splenectomy you have told.
Yes. Sir, 10 years back, she had taken steroids, glucocorticoids for 4 weeks, for a period of 1 year, and then she stopped the treatment. And when she developed SCH with SDH, she had received IVIG, sir.
So was she responding to glucocorticoids or not?
No, sir. She had in between mucosal bleeds present, sir.
Okay. So in the beginning of the first year, she was exposed to the first line of treatment, glucocorticoid, and
Yes,
she didn't respond to the therapy. Or
yes,
she
sir.
initially responded and later became resistant.
Initially responded, sir. Later again, she developed
Become refractory to
bleeding matter.
therapy. Okay, now we'll finish up glucocorticoid here itself instead of going to the end of. So first year she took glucocorticoid. And what is the mechanism of action of glucocorticoid in ITP?
Glucocorticoid can inhibit the phagocytosis of antibody-coated platelets by macrophages.
Excellent.
Other is decrease the autoantibody production.
Okay,
And
so it is that's called, it accelerates the apoptosis of the lymphocytes which produces the autoantibodies.
antibody.
So that is the main mechanism of glucocorticoid. So it enhances the apoptosis of the autoantibody producing lymphocytes. That's the first mechanism. Second mechanism is it decreases the
Autoantibody production.
macrophage consuming
It inhibits the phagocytosis of antibody-coated platelets by
macrophages. So these two are the main mechanisms of glucocorticoid action. And the patient will respond to, so if at least they should partially respond. If any patient doesn't respond to glucocorticoid, you may have to think of alternate diagnosis. So they have to initially at least partially respond. There's no response at all, you have to think of, okay, what are different protocols for giving glucocorticoids?
Newly diagnosed ITP, sir. With the platelet count less than 30,000 with bleeding manifestations, initially we start with glucocorticoids.
What are different glucocorticoids you can give?
We can give prednisolone, dexamethasone, or methylprednisolone.
Can you tell the dose of each?
Prednisolone, we can give 1 to 2 mg per kg. We can start, sir. And we have to monitor after 3 weeks. Initially, platelet count raises by after 1 week. Initial response occur within 4 to 14 days, and maximum response occur within 4 to 28 days. And if patient doesn't respond after 3 weeks, we have to switch over to the second line therapy, sir.
Good. So you are told prednisolone. And what is the dose of dexamethasone?
40 mg per day, sir. We have to give for 4 consecutive days for a cycle, and we have to repeat the cycle after 2 weeks, every fortnightly, 4 cycles we have to repeat, sir.
So minimum
2 weeks
of 4
apart.
cycles. Now they have enhanced, you can go even up to 6 cycles. So which I used to teach, it's FFF. So 40 milligram, 4 days consecutively, fortnightly, 4 weeks.
4 weeks.
4 cycles, sorry, 4 cycles. So minimum of 4 cycles. So it's to be given intravenously. We give preferably as an infusion instead of, okay. So methylprednisolone?
Similar to the dose of this, we can give 1 gram per day, 1 to 3 days, sir.
Okay, maximum of 3 days. That's called pulse therapy. So pulse dexamethasone, pulse methylprednisolone,
Methylprednisolone.
or 1 to 2 milligram, that's called moderate dose of oral prednisolone. And if the patient is pregnant,
We have to start on low dose steroids, prednisolone 10 mg per day.
so ideal is prednisone or prednisolone.
Prednisone, sir.
Prednisone is very ideal. Prednisone is a prodrug that has to be converted to prednisolone, that gets converted in the liver. Fetal liver is not capable of converting this. So it will not reach it. The fetus will not convert it. So, and the placenta does transmit all the steroids, but it transmits less of prednisone and prednisolone. So, placenta transfer is less, and the conversion of the prodrug prednisone to prednisolone is also less. So, that will be the ideal drug if available. If not available, prednisolone will be the best drug. Okay, so that is about steroid. It will take minimum of 2 to 3 days to have an action, and it will take even 14 days. And you can take a second call only at the end of second week whether the glucocorticoid is
continued
or not. Okay, and you should be aware of the side effects of glucocorticoids also. Okay,
Yes.
so she was given glucocorticoids for the initial 1 year, and she responded initially. Later, she became refractory. So then, what was given to her?
IVIG was given, sir, when she developed CH. When she went for altered controlling, patient was diagnosed as CH with SDH, sir. Platelet count less than 10,000. Then she was given IVIG, sir.
Okay, now we'll discuss about IVIG. So this is also will also come under the first line therapy.
Yes, sir.
What is the mechanism of action of IVIG? In the
FC receptor of macrophage, sir.
Okay, it's the same. The second action of steroid is the main action in IVIG. So it will inhibit the macrophage phagocytosing the antibody-coated platelets. That is the main action of IVIG. Okay, and what's the dose usually give in ITP?
Sir. 1 to general 2 gram per kg dose, sir. We can give as 0.4 gram per kg for 5 days, or else 1 gram per kg for 2 days.
So the second is the preferred option in ITP.
For 5 days.
Second, that is 1 gram per kilogram body weight. And because there is one option in that you give 1 gram per kilogram body weight in the first day, and after 24 hours you do a platelet count. If the platelet count is more than 50,000, you can defer the second dose. So you can stop short with 1 gram per kilogram. So that's the main difference between giving immunoglobulin IVIG in GBS and IVIG in ITP. So the preferred is 1 gram per kilogram in the first day. After 24 hours, do a manual platelet count, which I'll come again. And if manual platelet count is more than 50,000, you can
defer the
you can defer the second dose. You no need of giving the second dose of IVIG. And she has received a full course of IVIG.
Yes, sir. For 2 days she has received, sir.
Received. And what was the platelet increment? Platelet count increment. Was she responding?
She responded, sir. Exact platelet count not known, but bleeding manifestations has resolved, and patient at that time patient had menorrhagia and all. It resolved, sir, and patient went on.
So in the setting of ICH, so what should be your approach? You would like to give a steroid or immunoglobulin or platelet transfusion?
Sir, initially we give platelet transfusion, sir.
Good.
With IVIG, we combine therapy, sir. With IVIG with parenteral glucocorticoids, we give. In case of.
Okay, so the better is a combination of
therapy
platelet and the IVIG.
IVIG.
Because DEXA, we know it takes time to act. Glucocorticoid takes time to act. Now we want platelets; they act immediately. And if you combine with IVIG, what is the advantage of combining IVIG and platelet?
Because initially we have to give IVIG, then we have to transfuse the platelets, sir. Because
Yes.
IVIG can FC receptors are get blocked, so platelet transfusion will
Okay,
help
good.
to increase platelet count for initial period time. If you
So
initially give platelet, it will get destroyed, sir. So after IVIG, we have to transfuse platelet.
it is called as attenuated response. So unlike other people who receive platelet transfusion, the duration of stay of platelet in the circulation will be in ITP patient. If you give transfused platelets, it will be only for 1 hour. So
Okay.
at the end of 1 hour, it is back to square one. So only we give IVIG first, so that the platelet half-life of
Will be
transfused
increased.
platelet is prolonged.
Yes, sir.
So that is the main reason we have to combine IVIG along with the
Platelet transfusion.
platelet transfusion. And what platelet transfusion you prefer?
Single donor platelets, sir.
SDP, apheresis, that's called apheresis platelet,
Apheresis.
which can increase the platelet count by
More than 50,000. 50 to 60,000.
ideally 40,000. It is equal to more or less 4 to 6 units of random donor platelets. So that is the main advantage of a SDP is it can increase the platelet increment is high one. What are other advantage of SDP?
Alloimmunization will be reduced.
Alloimmunization, good. So if you're going to give multiple random donor platelets, so patient will develop platelet antibodies and they may not already they are existing antibodies, they may not respond to further. So alloimmunization and cytomegalovirus transmission, all these are
Indeed.
less if you start using SDP, single donor platelet. So but since she was admitted in our hospital, we do have a provision for SDP, but it will take time. So most of them, I think she must have received most of them an RDP. So at that point of time, she must have received an RDP and IVIG. And was she taken up for any neurosurgical procedure?
No, sir.
No. Okay, fine. So she came around well with the conservative management at that point of time. And thereafter, why she was taken up for splenectomy?
Patient again developed mucocutaneous bleeds, sir. Mucosal bleeds.
So
And
now she was on steroids after that 1 year and SAH.
yes, sir.
She was on steroids, then despite steroid therapy,
Steroid with immunosuppressants, azathioprine.
azothioprine. Okay, azothioprine, it is not a very wonderful drug, though hematologists do use it. Okay, okay, fine. So she and now her she was now then taken up for splenectomy. Okay, with all the precautions for splenectomy.
Yes, sir.
So what are the how do you prepare a patient for splenectomy?
If you are planning elective splenectomy, sir, we
Okay.
have to immunize the patient 10 to 12 weeks before 10 to 12 weeks before the procedure.
Okay.
And in case of emergency procedure, after
This is elective. This is going to be elective. It's elective. So what are the vaccinations you like to give?
pneumococcal vaccine, Haemophilus influenza type B, and meningococcal vaccine, and annual influenza vaccine at initial period, and then annually.
Preferably give pneumococcal 13.
PCV 13, followed by PPFC 23.
And if time permits, after 8 weeks, you can give PPV 23 also. So these are all to prevent what complication?
Abscess, sir. Overwhelming post-splenectomy,
Post-splenectomy
infection.
So that is, was that done for this patient?
Yes, sir. She was immunized.
Okay, so she was prepared well for splenectomy, and she has undergone splenectomy by laparoscopy or by laparotomy?
Open, sir.
Open. So
Laparotomy.
what should be the minimal platelet count for such surgeries, abdominal surgeries?
More than 50,000, sir.
Okay, more than 50,000 for
50,000.
abdominal surgeries. So for other surgeries, such as where do you want to keep the count around 1 lakh?
Okay. Other intracranial
Okay, neurosurgery, good.
and intraspinal surgery.
Neurosurgery, ocular surgery, and orthopedic surgeries. So these three surgeries, preferably you keep the count around 1 lakh.
Okay.
For abdominal surgeries and other surgeries, around 50,000. Even cesarean, it's enough if it is 50,000. 50,000. Okay. For lumbar puncture,
4,000.
70,000.
70,000.
so the the final word is it, because only the problem is epidural will produce more hematoma, and your lumbar puncture doesn't produce much hematoma. But the current up to date says if the patient has got hematological malignancy, you can even 20,000 sufficient. If it is a non-hematological malignancy, 40,000. But there's a difference of opinion regarding the count for doing LP. But if we're going to give neuroaxial anesthesia, that is epidural, it is minimum 70,000, as rightly pointed out. But 70 for neuroaxial, as epidural, all these things. But lumbar puncture, you can have a cutoff of around 50,000. 50,000, okay. For bone marrow, because you are supposed to do bone marrow in all these cases.
No cutoff is needed for bone marrow.
Bone marrow biopsy, it is around 20,000. Bone marrow biopsy preferably. And your old hematology book, D. Gurchi, he says no cutoff. Even with zero he can do, but the current up to date says 20,000. For both bone marrow aspiration and bone marrow biopsy, he says around 20,000. So 20,000 for bone marrow aspiration biopsy, 50,000 for other surgeries, and probably lumbar puncture, neuroaxial anesthesia, 70,000, and orthopedic ocular neurosurgery, 1 lakh.
More than 1 lakh.
So probably they must have kept around 50,000 by giving platelets. And it is said that if you just even clamp the splenic pedicle, so first they do that, the platelet count will increase sufficiently. Okay. And was it a good selection? How do you select the patient for splenectomy in ITP?
It is a second line treatment. Patient who relapse after the glucocorticoid therapy. In this case, patient also.
How will you predict? How will you predict?
When other modalities are.
I'm getting a emergency call. 1 minute.
Okay.
No clinical case has been.
Sorry, hello. Your Sharda?
Sir.
Sir, you can unmute yourself.
Yes, sir. Unmuted.
Okay, fine. So how will you select it? Because splenectomy is a very, very major procedure. And now this patient has ended up again with the relapse even after splenectomy.
Yes.
So could it have been avoided? That is, my question is, who will respond to splenectomy? How will you choose patients?
Like patient who are predominant splenic sequestration, we can determine by radioisotope techniques.
Good, excellent, excellent. So the first thing is young patient, they respond, basically.
Okay.
Second important thing is anyone who has responded to IVIG, we will presume they respond to splenectomy.
Okay, sir.
And third, as you rightly told, that is the investigation which is not available. That is called as, so you use a radio tracer
Isotope technique, radioisotope.
and you find out what is called as sequestration. And there are three types of sequestration: predominant splenic sequestration, predominant hepatic sequestration, mixed hepatic and splenic sequestration.
Okay, sir.
And predominant splenic sequestration, these people will respond very well to splenectomy. The other two people will not respond. So if the patient is young, if he is responding to IVIG, and if he has got a predominant splenic sequestration by radio tracer, then that should be the patient you have to take for splenectomy. Now this patient has again come to us because splenectomy, if you have chosen that right pathway, probably we should avoid the splenectomy. Anyhow, now what are other causes for relapse? One is a wrong selection, wrong choice.
Accessory spleen, sir.
Good. So accessory spleen and splenenculi. Splenenculi. So now how will you find out whether it is a wrong selection or the relapse is because of accessory spleen?
RBC scintigraphy.
Okay, now clinically, when will you suspect this is this ITP has relapsed because of wrong selection, or this ITP has relapsed because of accessory spleen or splenenculi? So if the relapse happens even immediately after splenectomy, it is the wrong selection. If it happens after a period of time, maybe 3 months or 4 months, initially they were responding, then they are going for relapse, then we think in terms of accessory spleen or splenenculi. So the time of relapse decides whether it is a wrong selection or accessory spleen. Accessory spleen. Okay. Now we have to do probably a nuclear scintigraphy to find out whether the patient has got accessory spleen. That is the cause for a relapse.
In peripheral smear, we can look for Havel-Jolly body.
The simple thing is whether patient has developed all the splenectomy patients should have immediately leukocytosis. That will be persisting for how many months? Leukocytosis.
3 months.
Okay, usually 1 month, and it will go off in 2 to 3 months, and they can have thrombocytosis and Havel-Jolly. What are Havel-Jolly bodies?
Nuclear remnants of RBC.
Nuclear remnants found in RBC, sir.
One is condensed hemoglobin. Okay. So Heinz granules, Heinz bodies, Havel-Jolly bodies, leukocytosis, thrombocytosis should be there in the peripheral smear in the post-splenectomized individual, at least initially. So if it is not there, you have to think in terms of probably accessory spleen or splenenculi. So now, by the history, now we are dealing with the case who is a case of chronic ITP who became refractory to steroid, and then was developed subarachnoid hemorrhage, given IVIG, and was on long-term steroid and azathioprine. Again, became refractory to therapy and was taken up for splenectomy. And what is the minimal duration of ITP to take up for splenectomy? Can I take all patients?
After 1 year, sir.
So minimum
Because
is
some
1 year.
patients,
Minimum is 1 year.
can become remission within 1 year, so we have to wait for
So
1
only
year.
chronic ITP patients should be subjected for splenectomy, not your routine ITP. So the time is minimum should 1 year, and after giving a trial of second line also.
Yes.
So are they given a trial of TPO?
TPO not given, sir.
So only after that it fails. So I think splenectomy is questionable in this case. Okay, anyhow. So okay, now we go to the. So with this in the background, after splenectomy, she has developed now all this. Okay, fine. On general examination.
The patient was conscious, comfortable at rest, pallor present, multiple purpura present, sir. Wet purpura present, no pedal edema, cyanosis, clubbing, icterus, and lymphadenopathy.
Okay, if she develops icterus, what will you think? What are the possibilities for icterus in her?
Autoimmune hemolytic anemia, Evans, sir.
Evans syndrome, that is a very, very important one.
Patient was on azathioprine, sir. Azathioprine toxicity can.
Good. And if there's any massive bleed anywhere,
Massive hematoma can consumption of.
Okay, they can produce that can undergo hemolysis, and you can have hemolytic pattern also. So there are umpteen number of causes of icterus in there. Okay, fine.
Vitals, sir. Pulse rate 86 per minute, regular in rhythm, normal volume, character, condition of the vessel wall normal.
Okay,
No
normal. Okay, fine.
BP 110/70 millimeter of mercury measured in right upper limb in setting position. SpO2 98% room air.
It's also normal. So anything else, CVS, not even hemic murmur is not there since he's pale. Okay. Now, per abdomen, no organomegaly, splenectomy, scar is there. Okay, sinus is there. So, splenectomized individual or asplenia individual, what's your comment in the case of ITP? A person with, when do you call hyposplenism? Hyposplenism. So, it's a hypo-functioning spleen or non-functioning spleen. So that can happen after splenectomy, after splenic irradiation, or after multiple splenic infarct. Okay, so your if a ITP patient has got hyposplenism, what runs through your mind? He or she is not an eligible candidate for
anti-D. She's not
good, excellent.
Anti-D can't be.
Anti-D will not work in a person who has got hypofunctioning spleen. And anti-D will not work in what?
HB should be mutant in, sir. RH positive individual.
Okay, so RH negative it will not work. It will not work. So to have anti-D to work, a patient should have intact spleen, should be RH positive, and should have reasonable hemoglobin.
More than of 10.
Produce
intravascular hemolysis.
So the anemia will worsen. So you should have good. So it is sacrificing the RBC for protecting the platelet. So because that the antibody will be directed towards that particular RBC rather than platelets. So it's going to be a transient effect. We have given anti-D in our hospital for 2 cases. HIV case, because they didn't respond to all these things, and they responded very well to this anti-D. But patient should have intact spleen and should be RH positive and should have adequate hemoglobin. Then only we can try this. Okay, fine. Proceed.
Systemic examination. CVS X1 S2 present. Respiratory system bilateral air entry present. Per abdomen soft, no organomegaly. Splenectomy scar present. Discharging signs present. CNS conscious oriented, moves all 4 limbs. Coming to investigation, sir. Total count 6,700. Hemoglobin 9.8 grams.
1 minute.
Platelet count 8,000. MCV 85.6. Red cell distribution width 19. Urea create 36.9. RBS is 296. TSH 0.09.
I missed the first slide, the previous slide. Can you go back to the previous slide? Okay, we'll comment on this. So whenever you order for platelet, what are the things you would like to have?
Mean platelet volume and
pardon?
Mean platelet volume, sir.
Okay, so you have to order for what is called as a platelet indices. And basically, manual platelet count. Always you compare the automated hemogram platelet with the manual platelet count. There will be usually a mismatch.
Yes, sir.
So first thing, why there's a mismatch, particularly in ITP?
Different sizes of platelets.
Different sizes of platelets, sir. We count in 2 to 20 femtoliters.
Good. So ITP people will have more fresh platelets, which will be the size of a WBC, which will be measured as WBC by an automated hemogram, and they will be having they'll be giving a falsely low platelet.
Low value.
So that is the main reason. Always you think in terms of manual platelet count. They have to count 1. Okay, then you have to go again by MPV. Okay. So what can you tell me some few causes for thrombocytopenia with what's the normal MPV?
7 to 11, sir.
7 to 11 femtoliters. If it's less than 7, it is microplatelet. So thrombocytopenia with microplatelet.
And Viscott-Aldrich syndrome, sir.
Good, excellent. And the second, there are very many conditions. You remember 1 or 2. X-linked thrombocytopenia, XLT and Viscott-Aldrich. Good. And the thrombocytopenia. Pardon?
Aplastic anemia also, small platelets.
Okay. Thrombocytopenia with the increased mean platelet volume.
Bernard-Soulier syndrome.
Good.
Gray platelet syndrome. ITP itself. And MDS.
Okay, so we differentiate like that. And here MPV will also be increased in ITP. Okay, fine. That indicates okay. Now with this 8,000 platelet, one person 8,000 platelet is because of aplastic anemia. Another person 8,000 platelet is because of ITP. Who will bleed?
Aplastic anemia will bleed, sir.
Why? Why this different?
Here, in case of ITP, one platelet can hyperactive platelets are there, sir. One platelet can function as 100 platelets, sir.
So ITP people, that's a discordance between the number of platelets and the bleeding tendency, because it is mostly an young platelet who are like young PGs like you. So aggressive and they hyper functioning platelets. So, but aplastic anemia, it is bone marrow failure, and those platelets are senescent platelets, dysfunctioning platelets. So, platelet count will not be an important indicator for bleeding as far as ITP is concerned, because they are all young, energetic, and hyper functioning platelets. Okay. And can you have bleeding with the 50,000 platelets or 70,000 platelets?
In case of dysfunctional platelets.
Okay, so there are a few conditions wherein patient will have thrombocytopenia with dysfunction, platelet function abnormality. So if the platelet count is normal or just normal, but the patient is still bleeding, think in terms of platelet functional disorder. And what does you do to find out that platelet functional disorder?
Aggregate functional test, sir. We can go initially, we can screen with platelet function analyzer 100, sir.
Okay. Lateral function analyzer, and then now it is 200 is also available.
Yes.
Or platelet agrigometry or thromboelastography, TEG.
Thromboelastography.
So platelet function can be assessed by that. PFA 200, TEG, or platelet agrigometry. So there are situations where a patient can have thrombocytopenia and okay. Oh, any other cause for thrombocytopenia with severe bleeding? Hematological condition. Which
Acute thrombocytic leukemia.
one Librand will have thrombocytopenia? Type 2B, type 1 Librand disease will have thrombocytopenia and bleeding. So that is thrombocytopenia will not be very much. So it will be around 70,000, 80,000, but they will have factor 8. What's that? 1 Librand factor efficiency. So when the bleeding is disproportionate, think of platelet functional assay or 1 Librand type 2B.
Type 2B.
So platelet indices is important. Don't go by just automated hemogram. Manual platelet, MPV is must to diagnose the cause for. So with the advent of then any other thing we have to look for in the platelet indices, which we do routinely.
Platelet distribution width.
IPF. What is IPF?
Immature platelet fraction.
So that will also give, that is more or less equal to a bone marrow. What is the normal IPF?
Less than 1 to 6, sir.
Okay, and so it is around 6. It's around 6. So if it is 6 to 9, the bone marrow is functioning more, and more than 9, we had IPF with sometimes even 40. So in this immune thrombocytopenic purpura, the IPF will be markedly increased. That means the bone marrow is still, and at one stage of this autoimmune thrombocytopenic purpura, the antibodies can be even directed against the megakaryocytes. So if in any ITP, if the IPF is getting gradually decreased, we think in terms of bone marrow failure. Bone marrow failure also. In such case, your TPO
receptor agonist will not work.
May not act. Excellent. So there are all simple things by which we can judge. So who will respond to splenectomy? Who will respond to TPO? Who will respond to IVIG? So anyone who has got good IPF, we can even still whip the bone marrow. But when the IPF is low, there's no point in whipping the bone marrow. But so don't interpret ITP without MPV, without manual platelet count, without IPF. Okay, good. Proceed. And she score is 296. Okay.
TSH 0.09, pre-T4 1.91, VCTC non-reactive.
So now TSH, because there are very many instruments using measurement for TSH and FT4. And so now this TSH is normal.
She is on treatment, sir. So less than 2 is suppressed.
So now probably she has gone for iatrogenic thyrotoxicosis. So now she is on how many microgram of thyroxine?
50 micrograms.
So probably may have decreased it to around 25.
Previously she was 100, sir. Now reduced to 50.
50. So because I already told, there's a chance for thyrotoxicosis in this patient. So now it is probably drug induced, but anyway, we have to keep that in mind also. Okay.
Peripheral smear.
VCTC is non-reactive, so we have to screen for VCTC in all these individuals.
To rule out secondary ITP.
Secondary HIV related. That can be the earliest manifestation of HIV. And how will you manage this HIV thrombocytopenia? HIV secondary ATP. So steroids are contraindicated. You don't give steroids. Sometimes ART itself
If
Will?
patient is bleeding, sir, we can give platelet transfusion
Good.
and IVIG, sir.
IVIG can be given, but I told you already we have given anti-D also to HIV individual. We had reference and we have given an anti-D. Patient responded, but steroids should not be used. Okay,
Yes,
and the purpose of doing viral markers?
HCV can cause secondary ITP, sir.
Okay, there also you have to only start heart, that is not steroids. Hepatitis B can also produce.
Yes, in endemic areas, hepatitis B can produce.
Okay. Any other investigation regarding the etiology?
H. pylori.
Why that was not done in this case?
So previously done, sir, it was negative, sir.
Negative. So if it's H. pylori, if you can, what are the investigations you do for H. pylori?
Stool antigen test, sir.
Okay, stool antigen, that is supposed to be the test
Pre-
or serological antibody or endoscopy. You can do a rapid urease test. Okay, all this can be done. Good. There are some advantages, disadvantages of it. Now we are happy with doing H. pylori antigen in the stool. Okay, so that must also be done. Okay, and then should we do CMV virus, EBV? They can also be triggers. Okay.
Yes, sir.
Okay. Peripheral smears shows thrombocytopenia.
Microcytic hypochromic anemia.
Okay. And in one field, minimum platelets should be to diagnose thrombocytopenia, because generally they give platelets adequate. That is the word they use by pathologists after. So if it is around 10 to 14 per field, they report as adequate. Okay. If less than 10, it's probably they put a mark at thrombocytopenia for clinical correlation. Okay.
Coming to ultrasound abdomen and pelvis,
Okay.
liver normal size, kidneys are normal, and drain tube type tract noted in left lumbar region, and no significant collection is seen.
Okay.
Diagnosis, primary hypothyroidism, refractory ITP, type 2 diabetes.
What is a primary hypothyroidism? On what bones are telling?
The patient has high TSH with a low free T3 and T4 levels.
Hi, Henry.
No,
Happy
currently
New Year.
TSH is suppressed.
During diagnosis, she was diagnosed as primary hypothyroidism.
Okay, so clinically, if the patient has got goiter, that would strongly favor
primary hypothyroidism. And antibodies also favor primary, sir.
Okay, anti-TPO antibody, all this thing, and all features are florid with primary hypothyroidism and less florid with secondary hypothyroidism. Okay, now type 2 diabetes.
Splenectomy with drain at fistula.
Okay.
Well, not see your screen though, but.
Oh, you wanted me to share. Sorry. I thought you were sharing. Extremely sorry. I'll share it, yes.
Okay. Now this is a diagnosis. What you are going to do further?
We can start TPO receptor.
Yes.
Okay. So such as?
L-thrombopag and romiplasty. Because L-thrombopag is oral, we prefer L-thrombopag, sir.
Good.
Dose is, we can start with 50 mg, sir, OD. Okay. We can maximum go up to 75 mg.
And side effects of L-thrombopag?
No.
It can cause thrombosis.
Yeah, from our side, the EX is released.
Sir, 1 minute. The execute team, your audio is on. Can you please mute your audio?
Officially, it's released.
Execute team, can you please mute your audio?
Yes.
Okay, Sharda. So side effects of L-thrombopag.
Right.
GI side effects like abdominal pain, sir, and thromboembolic episodes can occur,
Good, good.
hypertension, psychological disorders.
Sure. And particularly if you use in a cirrhotic, portal vein thrombosis.
Portal vein thrombosis.
And so, which TPO is preferable in a cirrhotic, which has got lesser incidence of portal vein thrombosis?
Thromboplastine.
So can you please share your screen?
Again, there is an interference with Exicon.
Yes, sir,
Exicon
please.
team is okay.
Evatrombopag and lusotrombopag.
Okay, Lucy back the incidence is
In
less.
this case, we are as we spoke last time, Henry, that we will be getting the OATP results by 3rd of February. So if that's the case, then yes, we can provide you with a schedule that if we get it on 3rd, how can we take this ahead and how much time do we need? Henry, would you just mind if I take 1 minute, please? There's someone on the road. Just a minute, please. So sorry. 1 minute. So are we ready? I mean to go live? Yeah. Okay, sir. I'll give you the countdown. So just allow me a minute, please.
Hello, sir.
Okay, I think we can now resume.
So just a minute.
You can post your next slide, Sarada.
Okay, so we are going live in 5, 4, 3, 2, 1. We are live.
Treatment, sir.
Yeah. Hi, Henry. So sorry. To keep you waiting. Yes. So yeah. So considering that we get the OATP result on or before 3rd of March, basically, we can I can sit with the team for this program GCZ 33303, and by tomorrow I can come up with a schedule. Considering we start on 3rd.
So we are Exicon IT team. So, sir, we are totally unaware of what is happening.
Sure.
So we are in that teaching session now.
1 second. Let me.
And we are not aware what is happening between you and the organizers. So can you please allow us to continue our program, and we'll come to an end shortly. Exicon IT team.
Yes.
Yeah. Because another 10 to 15 minutes, I think we can finish up this program. And we are not the organizers. And you can contact our organizers for further details. Okay? I think I'm clear. Okay, Sarada. So now we want to try
Yes.
only thrombopoietin receptor agonist. That's only left out option. Any
Yes,
other
sir.
option left out?
So for ECZ 78902, we are all ready from our side. There's just one approval that's needed from the field engineer. Without that, it's difficult for us to move ahead. So yeah.
Hello, sir.
I'm just trying to reach the Exicon team. They're not they're still responding. Really sorry for the inconvenience, sir.
No problem.
I'm just trying to reach. I even send a message also. Exicon, can you please mute yourself? It is disturbing our discussion. Exicon team, IT team, please mute yourself.
And is there any possibility for us to mute them?
Our host, usually they make me to be co-host or host, but our host, we cannot do the unmute or mute. I sent a message twice or thrice. He has not responded. Exicon team, please mute yourself. It is disturbing our discussion.
Sir, actually, he's in another meeting, sir.
Yeah,
நம்மளோட
correct.
இதுவும் ஆன்ல இருக்கு. He's on another meeting also. That is
அப்பனா
why.
கண்டிப்பா அவர் கேட்க முடியல. He should be able to listen to us. He'll be disturbing his discussion is in another meeting புரிஞ்சுது எனக்கு. But
இல்ல
should
சார்
be
அவரு
disturbing.
போன்ல வந்து இதை ஆன் பண்ணிட்டு அவர் சிஸ்டம்ல இன்னொரு இதுல பேசிட்டு இருப்பாருன்னு நினைக்கிறேன்.
So,
Okay, okay.
as per our conversation yesterday in the mail that I dropped you, so the thing is, there is one test
Exicon sir, can you mute yourself?
us to load this game multiple times and check. So now what is happening
Not
is when we
responding.
load this game multiple times, okay, we tested it for 20 scenarios, right? 20 times. So what happens is out of those 20 times, there is this one instance which gets failed, right?
Our
So
phone
the
number
game
இருக்கா sir?
is good.
இல்ல
Yeah,
சார் number இல்ல
we
just tried பண்ணி
keep a
சொல்லிருக்கேன்
time
நானு.
span of
Because
15 seconds
main
between
manager
each time
number
we
இருக்கும்
load
but
this
இந்த
game.
personal number
We
இருக்கா
are
இல்ல.
not facing any issue with that.
இந்த number personal number இல்லை. அதான் பிரச்சனை.
நம்ம இப்ப
Exicon team.
sir, Exicon IT team, sir, can you please mute yourself? It is interfering with our discussion. Exicon IT team, are you able to hear us?
I think he is not responding, sir.
Okay.
சொல்லிக்கிறேன் பழனி பண்ணி சொல்லிக்கிறேன் நானு. I just made a call to him also to stop it.
Okay,
But,
okay.
yeah.
Oh, okay, fine. It is done.
Yeah.
It is done. Okay. Fine, Sharada. We had some breathing time. Okay. No problem. Now, what is left out in this case? Now, we are correct. We are gone the right track. We are going to start an ultrasound back. We know the side effects of all this. Lucid back will be a better option if the patient is a cirrhotic. Okay, ultrasound is now really reasonably available here when compared to abort back and lucid back. Okay. And by the way, why do you want to give FS on alternate days? So this seems to be a first unit prescription. Only first unit we give.
Down regulation, sir. Pepsidin down regulation.
Okay, now there's a current concept for iron therapy. So for daily iron, you may not reach the therapeutic level. If you give on alternate days, there's a chance that your hepcidin may go down, and it will facilitate your FST, oral FST therapy. Good. So this is the current concept of giving iron therapy. And what is left out in here?
Give cyclosporin, immunosuppressants things we can use, but not that benefit. Can give cyclosporin, danazol.
They are all, I can say, even off-label drugs. Now we have tried the first line drug. First line, we have failed. IVIG, steroid, platelet transfer, they are first line. Second line, what was splenectomy? One. Rituximab, I have told the answer. So they are all approved. No, your cyclophosphamide, they are all, they are not very much studied drugs in ITP. There was previous CMDT even says all the drug, azothioprine, danazol, all these things. Now it is first line, second line. Second line is first is splenectomy, second is TPO, third will be rituximab. Now why not try rituximab in there? So before give rituximab, we have to screen for
infections. Hepatitis B.
Hepatitis B surface antigen alone is not sufficient. Hepatitis B DNA should be done because there are mutant strains which can be just hepatitis B surface negative. So you have to do HBV DNA, latent tuberculosis. So that the chance for reactivation of hepatitis B as well as LTB. So we rule out these two patients, you can very well start on rituximab. So that is the third. And the dose, 375 milligram per square meter. And all rituximab infusion should be given in ICU setup because rarely they develop ARDS. So it should not be given in a normal ward. What is the fourth drug? Postamatinib. So that is a monoclonal antibody. Monoclonal antibody. So first line will be always steroid, platelet transfusion, IV immunoglobulin. This is standardized nowadays. And the second line will be TPO,
rituximab,
splenectomy. And all your as this cyclophosphamide, danazol, azothioprine, they are not that much effective, but probably we can add. But these are the standard therapy. So now left out will be, in this case, will be first time imatinib and rituximab. So better we try that in this case if she is not responding to L-thrombobac. And okay, and there's any chance that what is a very rare possibility of refractory ATP?
Yes.
We have to rule out what is called as congenital thrombocytopenia.
Thrombocytopenia.
So that can present in adult.
Okay.
That can present in adult. So for that only I was asking about this MPV. MPV will be normal or even less in congenital.
Congenital thrombocytopenia.
So any who is she seems to be absolutely refractory to most of the therapy. So have that in mind also.
Okay, sir.
Rarest of rare, but that is a dictum given in most of the textbooks. Absolutely refractory so-called ITP rule out congenital thrombocytopenia that can present even in adult, not presenting in young age, can present even in adult. They have to rule out that possibility also in this case. And okay, I think your presentation went on very well and you have adequately prepared. You answered most of the question and more or less like a hematology DMPG. I thoroughly enjoyed your presentation, Sarada, and your discussion.
Thank you, sir.
Thoroughly prepared. You want to add anything else? You have got any more thing in the slide?
No, sir.
Oh, only thank you, slide. Okay, fine, fine. And have you got some time for the second presentation? It's already 9:45. And can Divya rush through your presentation shortly?
Yes, sir. Yes, sir, sure.
Okay, we'll have a glance of your presentation also. In another 15 minutes, we'll wind it up. Yes, start presenting, Divya.
Yes, sir.
Hmm.
Good evening, sir. I'm presenting a case of our patient is a 19 years old male, known case of hemophilia A for since 6 months of age, presented with swelling of left knee since afternoon. He developed this swelling spontaneously since afternoon, associated with pain. There is no history of trauma, no history of fever.
So, what is RI in hemophilia?
The patient will feel mild discomfort just few minutes to hours before the bleeding episode.
Good. So, at that time itself, if we can identify and you start your transfusion, you can prevent a catastrophic joint damage. Okay. So, what do you mean by target joint?
When the target joint, when a particular joint gets recurrent bleeding, usually the spontaneous bleeding will be more than 3 within 6 months of period.
Good. So, there's a more than 3 episodes within a span of 6 months. That is called the target joint. Okay. Now, has he got any target joint?
Yes, sir.
Which is his target joint?
Left knee joint.
Okay, fine. From 6 months of age. Now,
Yes.
Currently he's around what is his age?
19 years, sir.
19 years. So, okay, proceed. Next, you can go to the next stage. No, then you can skip. Next.
Past history. There is a history of multiple bruises at the age of 6 months noticed by his parents and evaluated in a private hospital and diagnosed as severe hemophilia A.
When do you
History of
consider hemophilia?
when the factor rate percent activity is less than 1%.
Good. If anyone has got less than 1% and if he's not bleeding, is there any possibility? So there are situations where they are called co-inheritance. Co-inheritance of a bleeding diathesis and a thrombotic disorder. So, so in this patient, if you have got hemophilia plus factor V mutant Leiden or plus protein C, protein S deficiency. So there are instances where they can have co-inheritance of a bleeding diathesis as well as a
Thrombotic disorder.
thrombotic disorder. So ultimately, they may not bleed. Okay. And which hemophilia patient can have lesser incidence of bleed as age advances? Or sometimes they can even go for remission. So there is particular variant in hemophilia B called as Hemophilia B laden.
Okay.
The problem is in the mutation of the promoter gene. So, promoter gene mutation, hemophilia B patient, as age advances, they can even go for remission. Similar to Glanzmann thrombocythemia people, as age advances, the bleeding tendency comes down. Okay, fine. So he was on demand. He was not on your prophylaxis.
Not on prophylaxis. History of profuse bleeding after oral trauma at the age of 5 years, managed with packed cell transfusion and fresh frozen plasma. History of left knee hemarthrosis at the age of 9 years and treated with fresh frozen plasma. History of left knee hemarthrosis around 10 times at the age of 14 years and each time treated with factor 8 in private hospital. But there is a minimal swelling and pain present in the left knee since then.
Okay, fine. Next.
Patient was on on-demand factor 8 treatment.
Good.
And started to receive
ideal candidate for prophylaxis. Okay.
He started to receive prophylaxis from our GH for past 1.5 years. 1 to 1.5 years.
Then that's fine. Now, this current episode is during his prophylaxis?
Yes, he is actually irregular on prophylaxis. He sometimes comes weekly once, sometimes never comes, sometimes on weekly twice.
If despite normal prophylaxis, if they develop bleeding, what do you call that? It is called as breakthrough bleeding. A patient on hemophilia prophylaxis receiving routine normal prophylaxis, despite the prophylaxis, if she develops bleeding, it's called as breakthrough bleeding. Okay. Then next slide.
Family history. The one shown in the arrow is our patient. He has an elder sister. His nephew also got hemophilia A diagnosed, and so his sister might have been carrier, and her mother
can
might
carrier
have been
manifest.
Sorry, sir.
Manifest carrier. Is there anything called as manifest carrier?
When there is chromosome inactivation.
That is female hemophiliac.
Okay.
Female hemophiliac, they are different. Manifest carrier is different. Hemophiliac, when the Turner or when because of
lionization, X chromosome inactivation, or X chromosome mosaicism can cause.
So your homework will be go and read what is called as manifest carrier. Can carrier manifest?
They can manifest during obstetric.
Excellent.
During during delivery, they can.
During delivery, they can manifest. That's called whenever the carrier they are subjected to what is called as a hemostatic challenge. That is the terminology. So there are certain hemostatic challenges. So one just challenges during delivery, and try to find out other challenges and what are the causes for manifest carrier. Manifest carrier, and you already told female hemophiliacs. Okay, fine. Next.
On examination, our patient is conscious, oriented, afebrile, moderately built and nourished. There is no palarectal cyanosis, spreading or lymphadenopathy. His weight is 46 kg.
Rush through.
Weight is stable.
Okay.
Examination findings are normal.
So now local examination, the patient has got any deformity?
Yes, sir. There is a unilateral genu varus deformity present.
Okay, which was preventable. Okay, then
diagnosis.
Okay, they made a diagnosis. So how did you make a diagnosis of without inhibitors?
Because patient responded every time when he receives a factor 8. So.
So, but we expect because it's early onset of age, and who are all prone for developing inhibitors?
When the severe hemophilia.
Good.
And the gene mutation is large deletion with the inversion crossing over of intron 22. When there is family history of inhibitors.
Excellent.
And the early exposure of factor 8 within
exposed earlier by 6 months. I think, okay, early exposure, severe hemophilia, And
And then they have received higher dose of factor VIII during trauma and surgery.
good. So these are the people who are prone to develop inhibitor, but now fortunately has not developed inhibitor. Good. Investigations.
Sir,
I got it.
no, sir. I gone with the
Okay.
treatment, sir. He was admitted for 1 day only.
Okay. Now, such patient we have to screen definitely for inhibitor.
Yes, sir.
So factor VIII assay is a must, and
Okay.
if a severe hemophilia patient is bleeding, but factor VIII assay is normal, what will you think? Okay, because the higher hematology, I understand. You have to think the patient is on emcizumab. When the patient is on emcizumab, what is emcizumab?
It's a bispecific humanized monoclonal antibody which binds both activated factor 9A and zymogen factor 10 and mimics like a activated factor 8.
Excellent. So it mimics. So this will give you a wrong factor VIII value. So if the patient is on emcizumab, your conventional factor VIII assay will be misleading. We have to go for what is called as a chromogenic assay with bovine plasma.
Okay, sir.
So if a hemophilia, because nowadays we'll be getting such cases,
Okay, sir.
emcizumab, and
Okay.
government is approving emcizumab. We'll be having the emcizumab soon even in our armamentarium of GH. So your conventional plasma 8 assay may be misleading you. Okay, so you was treated with factor 8. Okay, by
Based
calculation.
on his weight
Okay.
and joint involvement.
So what is the half life of your factor 8?
8 to 12 hours, sir.
So
Standard.
if it is ideally you have to give twice a day.
Yes,
And
sir.
if it is factor 9, it is once a day. So that's called as SHL. What is SHL?
Standard half-life,
Okay.
factor 8.
Now we have got EHL.
When the factor 8 is fused with the FC portion of immunoglobulin or albumin or pegylated interferon, they are extended half-life.
Extended half-life. Now future will be more of extended half-life rather than standard half-life. Okay.
Okay.
He was managed conservatively with
Yes,
the
sir.
okay. Now if you say now we have to screen him for inhibitors. So what
Yes.
does he do for screening?
Mixing study will be done, sir.
Good. So what are the conditions mixing study will be positive?
When the patient, both in allo antibodies and auto antibodies, the mixing study will be positive, but we
Okay,
have to look for response at 0 hours and 2 hours, sir.
good.
There will not be any time independent antibody will be present in lupus anticoagulant induced
Okay.
inhibitors. But
Basically,
when
good. Low purpose anticoagulant, they can also be positive, and here also it will be positive. Good. And in hemophilia, we divide them into time dependent inhibitor and
time independent inhibitors.
inhibitor. So, for some, it will, for certain people, it will appear
Later,
late only. So, we have to conclude only after that they are called as time dependent inhibitors. Time independent, it will appear early as well as late. So, you have to classify them as time dependent and time independent. And sometimes we have to use 1:1 plasma and 1:4 plasma also. So,
okay.
for inhibitors diagnosis. Okay. Now, having made it, if it is inhibitor positive, what are the alternatives available?
We can go with a factor 7A infusion or FEBA, which is a factor 8 inhibitor bypassing agent,
Okay.
or we can go for immune tolerance induction.
Okay. So, how do you measure these inhibitors? On what
We
do
need
you
to, initially it was Bethesda assay, later it became a 9-man modified Bethesda assay.
say good? So, when do you call mild inhibitor? When do you call severe inhibitor?
When the inhibitor is low titer, less than 5 Bethesda units,
Okay, good.
and low responders.
They are called low responders. And if in them it is enough if you simply
Increased dose of factor 8 can be given on low
excellent.
responders.
Okay. In high responders only, we go for immune tolerance induction,
Induction.
ITI,
Hmm.
ITI. And a word about inhibitors in factor 9.
Actually, they are very less common because that is only 3% of prevalence is 3%.
Good.
Factor 9.
And it's very difficult to try immune tolerance induction in them. They go for anaphylaxis.
Yes, and nephrotic syndrome.
Nephrotic syndrome. So it is very difficult to try immune tolerance induction in factor 9 people. So
Okay.
now this person is already diagnosed and he has got recurrent bleed. Now there's a paradigm shift in the treatment. We had initially that is plasma derived factors.
Yes, sir.
That was
Now recombinant factors.
then recombinant this factor 8, that to standard half-life, extended half-life. Then we had bypassing agents, phebacetol or activated factor 7 or emcizumab. Now, what is the current in the future? Probably after
Tissue factor pathway inhibitors like concizumab can be used.
concizumab. That is very well available abroad. So now we are shifting the patient from a bleeding mode to a thrombotic mode.
Thrombotic. Okay.
So diametrically opposite mode. So the chances of thrombosis is also high. So uh, that's one thing called factor 8 mimetic. MIM. Have you heard of that? Factor 8 mimetic, and that's also a thrombotic mode. And as you know, concizumab is upcoming drug, very costly drug, but the future will be more of those drugs rather than factor replacements. So future will be that. Is there any genetic drug?
Gene therapy has been tried, but they are tried mostly in factor 9 because of the small size of the gene. But in factor 8, B domain deleted factor 8 can be tried for gene therapy.
So factor 9, it has been successful and it's supposed to be the costliest drug available, gene therapy in factor 9. So two drugs are very costly. One is for SMA, you must be aware, spinal muscular atrophy, that drug, as well as this hemophilia B gene therapy. So they are the two costliest treatment across the world. In future, okay. So now you have to follow this patient at any point of time. You will develop inhibitors. And before, how do you manage him before any surgery? With that, we'll call it a day.
Factor 8 should be maintained at 100% level just a few hours before the surgery, and it should be maintained for 7 to 10 days after the surgery or until the complete healing of surgical site wound.
And you have to screen for inhibitors before surgery. Definitely, it is a must.
Okay, sir.
Okay, pa. Anything else? You must have read more about hemophilia for this presentation. You want to add anything else?
I would like to ask a question, sir. Because when we read, all the factors are produced by liver except factor 8, which will be produced from endothelial cells.
Good.
But why we are doing liver transplantation in hemophilia A patients?
It is not, we are doing liver transplantation is not at all a recommendation. It has it has been found that one person went for remission. That it was, if I'm correct, it is factor 9. I have to check, but it only factor who had deficient of factor 9 went for remission after liver transplant. But liver transplant is not a accepted therapy. Accepted therapy for factor 9. So he has gone for remission. That's all.
Okay.
But it has not been proved whether that is going to be the treatment. That is going to be the treatment.
Okay, sir.
Okay, pa.
Thank you, sir.
Thank you, pa. We had to cut short your presentation because of want of time. But we had a very rich hematology discussion today. I was thoroughly satisfied with both of your presentation. I can pull off my collars because you are my students. Thank you. And again, I thank sincerely Payas who has left our department, but he has gone through all these 3 months exclusively, has devoted himself, and I think no other person could have done the job better. So he came to the department at the right time, and he has finished all the jobs excellent. Thank you, Bayas. You have done a
Thank you,
wonderful job. And
Thank you, sir.
again, Professor Saravanan sir, who is the architect of this program, and he attends all the program. I was told all the programs, and really sincere thanks to you, sir. Uh, and
Really,
again,
thank you, sir, for even every program I'm attending, I'm getting a more information. I learned a lot of hematological point, even though I'm very much fascinated about hematology, practicing extensively on hematology in our institution also. But
okay, okay.
each and every day, the practice is going to be more and more with the new information which you're learning through listening. Because sometimes, as you know, that's very difficult to learn on a daily basis, the books or the other information. But listening to the information of this nature from different professors and learned people, even the energies of these postgraduates teaching us a lot,
Yes,
especially
exactly.
both the postgraduates learned a lot. I think I should appreciate both the postgraduates for the complete exercise done by them, preparing themselves for this presentation and the discussion also. Yes, Professor Narajan sir was mentioning about it's a hematology PG discussion like. Similarly, it was an excellent level of discussion, and they're able to answer all the updated questions related to the hematology. Really appreciate both the postgraduates. Definitely, the credit goes to the unit chief as well as the head of the department for appreciating as well as encouraging them to learn more and more. Definitely goes to you also, sir. Really, thank you for the last 16 weeks being with us for conducting this program in a nice manner. Definitely, every post would have been benefited out of this presentation and discussion. And definitely, not the last, the Dr. Fayaz, as Dr. Professor Narajan sir was mentioning about, it was completely coordinated by Fayaz and excellently done a job, even though he's left the institution, he's moved to another institution. He's fascinated towards the teaching, shows this character of continuing the given job and responsibilities taken by him, and he completed his task. Really, thank you, Fayaz, for coordinating, and thank every one of the faculties and the postgraduates for the active participation. Thank you, and every one of you, and good night to all of you.
Thank you, sir. Thank you. I like to
Thank
thank
you.
Palniappan sir also, who is a man behind the screen for all these things. Thank you, Palniappan sir, even though he's off the screen. Thank you, sir. Thank you, sir. Good night, sir.
Thank you, sir. Good night, good night, sir. Good night.
Thank you. Good night, sir. Thank you.
Good night, Fayaz.
Thank you, sir.
Good night.
Thank you.